Good morning, good afternoon, or good evening, and thank you to the organisers for the opportunity to present. Over the last few years, more and more countries have been scaling up PrEP as an additional HIV prevention choice in our region. Countries such as Thailand, Vietnam, Cambodia, and Nepal are actively scaling up PrEP programs as part of their HIV prevention response, but many others are in the early stages of implementation. And while there are more people than ever taking PrEP in Asia and the Pacific, globally we are lagging behind. Asia Pacific accounted for less than 10% of PrEP users globally in 2020, and currently in our region we have only achieved about 2% of the UNAIDS 4 million person target for Asia and the Pacific for 2025. The number of users is not proportional to HIV incidence or to prevalence, to PrEP need, and is not yet enough to affect the course of the epidemic. And this is particularly a concern with the rising epidemics across our region, especially when remembering that it is important that PrEP is rolled out at scale to achieve impact. Timely and evidence-based global guidance is important to help PrEP implementation at a local level. And we know that many countries within our region and globally look to WHO guidance. It's been a decade since WHO's first recommendation on oral PrEP, and 7 years since WHO's strong recommendation that PrEP should be offered to people at substantial risk as part of comprehensive HIV prevention services. As the evidence has evolved, so too has WHO's recommendations and guidance. In 2019, WHO added an additional dosing regimen for oral PrEP called ED, or event-driven PrEP, and in 2021, an additional PrEP product, the dapivirine vaginal ring, was added. Early guidance was cautious and based on the limited evidence, largely from high-income settings and trials, and took really a do-no-harm approach. We have significantly more experience now from real-world implementation and studies that we can draw on. And there is a pressing need to update our implementation guidance in line with the current evidence. This year, WHO will be releasing revised PrEP implementation guidance with a simplified and differentiated technical brief, as well as updates to the implementation tool, including the development of a PrEP and STIs module this year, as well as an update to the clinical module later this year. And WHO will be releasing a recommendation on injectable cabotegravir. So a note on these new PrEP products, because the guidance that I refer to a little bit later will refer to them. The dapivirine vaginal ring, I already mentioned, was recommended by WHO in 2021 and is a female-initiated option for pre-exposure prophylaxis with a greater than 50% relative risk reduction in the open label extension and possibly up to 70%. But we have no information on acceptability and feasibility within Asia and the Pacific, and it has not yet been included in any country guidelines or prevention programs within our region. However, countries in Africa are moving forward with it. Long-acting injectable cabotegravir is a highly efficacious 2-monthly injection based on, and the evidence for this was based on 2 randomized controlled trials. But we need implementation science to understand things like choice and enacted preferences. Do people want to take injectable cabotegravir, and do they prefer it to other PrEP options? Switching and continuation, as well as effective use, service delivery. In some key populations, there have been no studies, for example, in female sex workers, in people who inject drugs to date, and trans men were not actively recruited. And further information is needed on things like the testing algorithm and drug resistance. We also have limited information available on values and preferences in the Asia Pacific for injectable cabotegravir, but on a global level, the EOI for pre-qualification for WHO was released in April, and as I mentioned, a WHO recommendation is coming. So as I mentioned, the primary topic for this talk is around the upcoming WHO guidance for simplified and differentiated PrEP, which is coming in the middle of the year. The focus of this guidance is tenofovir disoproxil fumarate containing oral PrEP, but principles may be applicable to other PrEP products, especially the dapivirine vaginal ring, which has none of the safety concerns of oral PrEP or CAB-LA. And the only testing requirement of the dapivirine vaginal ring is HIV, is an HIV test. While CAB-LA has some specific characteristics, that may mean that this guidance is less applicable. So let's start with the kidneys. WHO has released new guidance on kidney function monitoring for oral PrEP based on an analysis of PrEP programs from across the globe, which found an overall low number of kidney-related side effects. As you know, impaired kidney function is a contraindication for oral PrEP containing TDF. The highlights from this guidance are that measuring kidney function is optional for those aged under 30 years without a kidney-related comorbidity. Individuals aged 30 years and older without comorbidities may be screened once at or within 1 to 3 months after initiation, but kidney function monitoring can be considered optional depending on the available resources for those aged 30 to 49, and particularly those aged 30 to 39, given the very low risk of kidney impairment. More frequent testing or screening every 6 to 12 months is suggested for individuals with comorbidities, those aged 50 years and over, and those with previous kidney function test results, suggesting at least a mild reduction in kidney function. Importantly, this guidance applies equally to daily and event-driven oral PrEP use. There is no difference between the dosing regimens. And kidney function measurement is not necessary for the use of the dapivirine vaginal ring, and we do not anticipate any kidney-related toxicity for the use of CAB-LA. The other one thing that I want to highlight from this slide is that waiting for kidney function monitoring results should not delay starting oral PrEP. As I mentioned, where required, kidney function monitoring can be done within 1 to 3 months after starting PrEP, and the results can be reviewed at a follow-up visit. So moving on to viral hepatitis. WHO guidance is set to be updated in 2022 regarding hepatitis B and C. In many settings, populations at risk of HIV are also at a high risk of hepatitis B and C infection. And PrEP services provide a unique opportunity to screen for hepatitis B and C and to address multiple public health issues. While PrEP services, while availability for or access to testing for hepatitis B and C may be an issue, this should never be a barrier to PrEP initiation or use. PrEP can be initiated before these test results are available, where testing has been conducted. And to emphasize, hepatitis B and C testing is not a requirement for PrEP use. Now, this is particularly important to note for hepatitis B because TDF based daily and event-driven PrEP can be offered to individuals with hepatitis B infection. And hepatitis B infection was previously a contraindication for ED PrEP. It's no longer a contraindication. The DVR can be offered safely to persons with hepatitis B and C. So HIV self-testing. As you will remember, one of the only absolute testing requirements for oral PrEP is HIV testing. HIV self-testing is a game changer for testing programs and potentially for PrEP programs as well. HIV self-testing can support differentiated service delivery approaches for oral PrEP, such as delivery outside of health facilities, including reducing clinic visits. And this is particularly applicable for follow-up visits by more experienced PrEP users. HIV self-testing may also be used to support services for the dapivirine vaginal ring. HIV self-testing supported PrEP services may be preferred by users because of convenience, because of privacy, or for self-managed care. And these differentiated models have the potential to remove barriers to increasing PrEP and thus increasing uptake, persistence, and effective use, which is ultimately what we really want. During COVID-19, HIV self-tests were implemented by numerous programs as a crucial measure to maintain PrEP services. And WHO has supported HIV self-testing in this role. HIV self-testing will be reviewed by WHO in relation to PrEP later this year for an update to further implementation guidance. And one thing that I'm very excited about is guidance on how to start, use, and stop PrEP safely in accordance with periods of risk. WHO will expand the eligibility for event-driven or ED PrEP-based dosing regimens to include all individuals who have been assigned male at birth, who are not taking gender-affirming hormones, for example, estradiol, and who have sexual exposure. And this includes cisgender men, transgender women, and non-binary individuals assigned male at birth, all of whom, as long as they're not taking gender-affirming hormones. Now, to take the dosing regimen, you would start with 2 doses, 2 to 24 hours before sexual exposure, continue with 1 dose per day, and stop 2 days post-exposure. One crucial thing to note here is that the starting and stopping approach is the same whether somebody wants to start PrEP for a single event, what we would probably more commonly know historically as event-driven PrEP, or to cover multiple events over a longer period of time. And this can be multiple events together and approximates daily PrEP. Importantly, as I noted for hepatitis B, hepatitis B infection is not a contraindication for this dosing regimen. Now, all individuals not eligible for an event-driven PrEP dosing regimen should use a daily dosing regimen. And so suitability includes individuals who were assigned female at birth, individuals who are assigned male at birth not taking gender-affirming hormones, and individuals with exposure through injecting practices. With the daily dosing regimen, you would start daily PrEP 7 consecutive days before exposure, continue with 1 dose per day, and stop 7 days post-exposure. Now, the big difference here to note is that previous WHO guidance recommended to continue PrEP, daily PrEP, for 28 days post-exposure to be fully protected. And this guidance has now, with the upcoming guidance, will be reduced to only 7 days. And this is supported by modeling of pharmacokinetics, as well as consideration of barriers to initiation and reinitiation of PrEP. And finally, as part of the technical brief on differentiated and simplified PrEP, is the consideration of differentiated service delivery. Now, differentiated service delivery has been a feature of oral PrEP services for a long time and has been a major contributor to oral PrEP scale-up in Asia and the Pacific in places like Thailand, Vietnam, Philippines. You'd be very familiar with the KP-led programs in Thailand, for example. By prioritizing the needs of the client, differentiated service delivery for PrEP makes PrEP services more person and community-centered, adapts the services to the needs and preferences of people who are interested in and can benefit from PrEP, may make them more acceptable and accessible by prioritizing those needs. Convenience is really key for the delivery of any kind of public health program. May support PrEP uptake, persistence, and effective use, again, by supporting acceptable, accessible, convenient services, and support efficient and effective use of healthcare resources. which is really important for policymakers and providers. The feasibility is well established, but additional evidence for effectiveness should be generated across multiple geographies and populations to support continuation of these and expansion of these types of services. And it's crucial for other PrEP products, like I mentioned, the Dipivirine vaginal ring, as well as upcoming products such as CAB-LA, to be able to be incorporated into differentiated service delivery to enable choice for people who could benefit from PrEP. And more work is really needed in this arena. So a common framework for differentiated service delivery when conceptualizing it utilizes 4 major building blocks: where, who, when, and what. And these building blocks can and often do differ between initiation, continuation, and reinitiation of PrEP. Now, for example, where could be places like service delivery in community health facilities, in fixed or mobile sites, in primary health, telehealth or virtual platforms, or a pharmacy. For who can deliver such services, this includes nurses, pharmacists, key populations and peers, community health workers, as well as, of course, physicians. And WHO really has recognized the importance of task sharing for a long time in situations such as ARV and testing centers. But for all providers of differentiated services, training and support is needed, the development of clear protocols and SOPs, as well as clearly defined roles and responsibilities and scopes of practice. Also, where it's not a physician who is authorized to provide a prescription, for example, there needs to be an authorization of whoever it is that's providing these services with clinical support and oversight. And a crucial element that is sometimes not mentioned is correct remuneration of the providers and the services that they work in. The elements of when include visit schedules and dispensing schedules. Multi-month dispensing is usually preferred by clients as well as by providers. And the what is that service package of initiation follow-up services. And this includes integrated services, harm reduction services, PrEP integration, and others. Now, bringing this together, we have many different examples of community-based PrEP delivery, and this includes mobile PrEP, tele-PrEP, home delivery of PrEP, and pharmacy-based PrEP. And these tend to offer convenience in terms of settings, geographical locations. For example, pharmacies are really widely available in much of the world, where clinics, or particularly HIV clinics, may not be. And opening hours may be much more acceptable and convenient for people. The acceptability of the location and the provider is also really important for this. And considerations around privacy and confidentiality, as well as the integration and referral to appropriate other services. One case study that I would like to highlight is in Vietnam. Vietnam introduced mobile PrEP and STI services in 2021 in 4 provinces to complement existing services and to better meet the needs of underserved populations who may experience barriers to accessing services. The teams included physicians, nurses, counselors, laboratory staff, pharmacists, and peers, and they provided a range of services from HIV and STI testing, counseling and assessment of PrEP, as well as STI treatment and referral to other services. The programs successfully supported the expansion of PrEP services and an increase in PrEP uptake, and will soon be expanded further. So the service, a summary of the principles of such services and what has proven successful includes that PrEP services need to be person-centered and integrated with the relevant services, that community sensitization and involvement all the way from planning to delivery is essential in establishing any of these differentiated models. Government support is needed to legitimize these services and ensure that the standards and the quality is met. That national logistics systems provide support so that these are integrated within the infrastructure. That adequate infrastructure in the physical space is provided, including HIV self-testing facilities and ensuring privacy and confidentiality, so physical space. That the data is captured and fed into national reporting, that the providers are authorized with appropriate clinical oversight, and that there are robust referral pathways for clients with complex needs, but also for other services that are important. So the technical brief is expected to be released this month, and we will be integrating all of this guidance into the update of the WHO implementation tool. As I mentioned, the updated clinical module will be coming late in 2022, and you can also expect a new module on PrEP and STIs in the second half of this year as well. This guidance represents a real opportunity for countries to update their guidance and their implementation practice to improve their PrEP services, to support increased access and uptake, and to scale up HIV prevention coverage, to better meet the needs of communities, but also to really make an impact on their HIV response and on HIV incidence within your countries. And now I would just like to take this opportunity to thank the organisers and to acknowledge that I am presenting on behalf of the HIV testing prevention and populations team at WHO, and acknowledge Robin Schaefer, who is leading the work on simplified and differentiated PrEP, Michelle Rodolph, who is leading the work on CAB-LA, as well as Rachel Bagley, our fearless leader. All of the contributors to the guidance development, thank you. And if you would like more information at any stage, please don't hesitate to contact me or Robin Schaefer. Our details are here. Thank you.